Good morning, everyone, and thanks for joining us today. We appreciate your taking the time. My name is Steve Smith. I'm Deputy Executive Director at the Workers' Comp Board. I'm joined this morning by Mary Beth Woods, Executive Director, David Wertheim, General Counsel, Heather McMaster, Deputy General Counsel, and I'd also like to do a thank you to Liz Locke for coordinating this morning's session, as well as Mike Gifford for facilitating the WebEx. As you're aware, the Workers' Comp Board formulary has been in place for about 18 months.
We've been hearing some issues from pharmacies and from injured workers regarding their ability to obtain medications, so we thought it would be useful to do a quick review of the structure of the formulary, walk through the prior authorization process, and review some of the issues that we've been hearing from pharmacies and from injured workers trying to obtain medications. And then we'll have time to open it up for general questions. So as you're aware, legislation was signed in April of 2017 that required the Workers' Comp Board to establish a prescription drug formulary by December 31st of 2017. On December 28th of 2017, the board released an announcement of the creation of the new drug formulary and sought public comments. In October of 2018, the board revised the proposed formulary and in response to public comments and released it for a second round of public comments. The adopted medical treatment guidelines form the basis for the drug formulary. Medications are added to the formulary based on their effectiveness and appropriateness for treatment of illness and injuries covered by the workers' compensation law. It should be noted that the formulary does not apply to drugs administered in the hospital or provider's office, but does apply to drugs dispensed by a provider. The formulary was adopted by regulation May 21st of 2019 and became effective June 5th of 2019. This meant that as of December 5th, 2019, all new prescriptions were required to comply with the formulary, and by June 5th, 2020, all refills were needed to comply with the formulary. Just as a note, a new prescription is a prescription for a drug that a patient is not currently taking. This could be a different medication or the same medication at a different dosage. A refill or renewal is a subsequent fill of a prescription for the same medication when the number of refills is explicitly indicated on the original prescription. Additionally, as you recall, the board had a requirement that no later than December 5th of 2019, payers were required to notify providers of non-formulary drugs that workers' comp patients were taking, to notify patients of non-formulary drugs that they were on, and the need to discuss treatment options with the providers. You're also probably aware that the date for compliance with refills was moved out to January 1st of 2021 due to COVID. It was subsequently moved, or it has subsequently been moved to a to-be-determined date, second quarter of 2021, and this is being done to align with the implementation of the board's new prior authorization system, which we refer to as Onboard, which will contain enhanced functionality for medication prior authorization. A specific date that will be going live with that will be announced in the near future. So the formulary consists, as you know, of 3 drug lists: Phase A, Phase B, and perioperative drugs. A specific framework has been established for the prescribing of drugs within each of these 3 phases. Phase A drugs are those drugs that may be prescribed and dispensed within the first 30 days following an accident or injury, or until the payer accepts the claim or the board establishes the claim, whichever comes first. Drugs on the Phase A list can be prescribed for up to a 30-day supply unless a special consideration is identified. Drugs on the Phase B list may be prescribed and dispensed after 30 days following an accident or injury, or less than 30 days after the injury if the payer has accepted the claim or the board has established the claim. Drugs on the Phase B list may be prescribed for up to a 90-day supply unless a special consideration is identified. Also, it should be noted that the Phase B drug is listed when a body part or illness has been accepted or established. This may occur within the first 30 days following the accident or injury at which point the Phase B drug list which should be used. Some Phase B drugs are designated as second-line drugs. This means that they may be prescribed and dispensed after an unsuccessful trial of a first-line drug prescribed in accordance with the Phase B list and the adopted medical treatment guideline as applicable. The perioperative drug list contains drugs approved during the perioperative period, which is defined as 4 days before through 4 days following a surgery. As previously described, some Phase B drugs are listed as second, meaning they can only be prescribed or dispensed following an unsuccessful trial of a first-line drug prescribed in accordance with the applicable medical treatment guidelines. Some drugs on the formulary carry a special consideration. There are 4 different types of special considerations. Special consideration number 1 indicates that a drug can be prescribed one time only without a prior authorization for a maximum of a 7-day supply. An example here would be a narcotic prescribed for acute pain following an accident or injury. Special consideration number 2 indicates that the drug may be prescribed and dispensed for the prescribed course of therapy. The example here would be an antibiotic. Only short-acting formulation of drugs designated with special consideration number 3 can be dispensed. Opioids and skeletal muscle relaxants are the primary examples here. Special consideration number 4 is as clinically indicated for causally related injuries or conditions utilizing accepted medical standards. Drugs in this category are available for treatment when there is no adopted medical treatment guideline for the established or accepted body part or condition, or for a condition directly associated with an established or accepted body part, but not specifically addressed in the medical treatment guideline. An example here would be the treatment of a post-op infection following a knee replacement, which isn't specifically addressed in the medical treatment guideline, or a medication for a patient who's been established for PTSD, for which there's no currently available medical treatment guideline. The formulary is arranged by therapeutic category. It is then arrayed by the generic name of the formulary drug. Relevant special considerations in the phase of the formulary for which the drug is designated are also listed. It's either incorporated into the Phase A list, the Phase B list, or the perioperative list. The medical treatment guidelines are listed and carry an indication that the drug is available as part of the patient being established for that body part, and the drug are identified in the medical treatment guideline. The drug is then either indicated as primary or secondary within that medical treatment guideline. If the drug is not listed under the medical treatment guideline for which the patient has been established, and the drug does not have a special consideration number 4 associated with it, a prior authorization request would be required before the drug could be prescribed and dispensed. So the example that we'll use here is naproxen or naproxen. It is on the Phase A list and can be prescribed for any injury or illness during the first 30 days or until the case has been established or accepted. At that point, either after 30 days or the acceptance by the payer or being established by the board, it falls into the Phase B category drug list. As a drug in Phase B category, it can be prescribed if the injured worker falls under one of the medical treatment guidelines where there is a yes, for example, elbow. If the injured worker falls under one of the medical treatment guidelines, for example, eye, an approved prior authorization would be required before the drug can be prescribed and dispensed. So if the claimant, if the injured worker hasn't been established for one of the medical treatment guidelines that is indicated with a yes, then a prior authorization would be needed. It should also be noted that some over-the-counter drugs are also included in the formulary. When written on a prescription, covered over-the-counter drugs should be processed by the pharmacy and paid for by the payer. Primary example here is lidocaine 4%. There's been a lot of confusion around this particular product, specifically because it's over the counter, but it is incorporated on the formulary and as such should be processed like a prescription. So that's basically an overview of the formulary. We thought it would also be useful to do an overview of the prior authorization process so that you all know what the provider is doing to get a prior authorization. When the prescriber needs a drug not listed on the formulary, a non-formulary prior authorization request must be submitted and approved before the drug can be prescribed and dispensed. Additionally, an approved prior authorization request must be obtained for a brand name drug when a generic version is on the formulary, and for combination products unless the combination is specifically listed on the formulary. An approved prior authorization is also needed for a brand name drug when a generic version of the same active ingredient is commercially available and on the formulary in a different strength. An example here is a product that is on formulary and generically available in 5 and 10 milligrams, and there's a 7.5 milligram version that's only available as a brand. The 7.5 milligram version would be considered non-formulary and therefore could only be prescribed and dispensed subsequent to an approved prior authorization request. A prior authorization request is also required for any compounded drug. To view and to respond to a prior authorization request, the payer would go into the medical portal and select drug formulary prior authorization in the treatment section. So since it's important for the reviewer to understand what the prescriber does to initiate the prior authorization request, we'll now walk through that process for you. Upon initiating a new prior authorization request, the provider will be asked to do a case search for the patient. To perform the case search, the provider must enter either the WCB case number or the claim administrator case number and at least 2 of the following: date of injury, last 4 digits of the injured worker's Social Security number, injured worker's date of birth, or injured worker's last name. Details of the search case are then displayed. If the case has been established, the body part for which it has been established will display, and that's shown in the bottom left-hand corner of this screen. If the case has not been established, information about the injury will be shown in the details section, including the nature of the injury, the body part, and the cause of the injury, and an injury description. There is a disclaimer that this particular case that's being shown has not been established, and therefore authorization it's not represented to be automatically authorized as a case. If the case is not found, it will show no results found. The user can either return to the search and look for a case, or can then select Start Blank Request, and will be prompted to enter information about the injured worker and any other demographic information that's available associated with the employer or the carrier. If the prescriber found a case, information about the case is automatically presented to them, as well as information about the injured worker, the employer, and the information associated with the payer, as well as the provider information. And this is the email address that is used for this particular prior authorization request to communicate with the provider. The prescriber then needs to provide clinical documentation justifying the need for a non-formulary drug. This can be done either in the form of free text or via attachments. The prescriber also needs to indicate whether the drug being requested is a narcotic, an anti-anxiety agent, spelled multiple accents, or none of those. They then provide basic information or general information associated with the drug that they're requesting, and when they're completed, they then hit submit. The request for that prior authorization is then automatically routed based on information that the carrier has provided to the board and is responsible for keeping updated in the system. The request automatically goes to the indicated level 1 reviewer, at which point the level 1 reviewer has 4 calendar days to review that request and either approve, partially approve, or deny the request. When they take action, that automatically goes back to the provider. We are requesting that when a level 1 review is done, the specific rationale that the provider provides for the prior authorization request gets addressed. When the request is reviewed, it automatically goes back to the prescriber. If it's been approved, the prescriber would write the prescription. If it does not get approved or is partially approved, the provider then has 10 days to determine whether or not they want to request a level 2 review. If they request a level 2 review, that automatically gets routed to the payer's medical director, as indicated in the system. That individual then has 4 calendar days to review the request and, again, either approve, partially approve, or deny. I want to note here that if the carrier is going to deny based on causality or acceptance, it should be done as part of the prior authorization request. We have seen instances where there have been approvals at one of the 2 different levels, but then there's an issue of payment because of causal relationship. So the reviews that are going on as part of the prior authorization process should not only be for medical necessity of the medication being requested, but also for causal relationship. So this is the opportunity for the carrier to deny based on whether or not the body part has been established or not. After the level 2 reviewer does their review, it automatically then gets routed back to the prescriber. Again, if approved or partially approved, the prescriber could write the prescription. If denied or partially approved, they could then request review from a level 3, which is the board's medical director's office. When the board medical director's office does their review, they are reviewing based on medical necessity only, and we have added enhanced language back to the provider that the review that the medical director's office is doing is for medical necessity only, and it doesn't infer guarantee of payment if the particular injury is not causally related or hasn't been accepted by the carrier. For the payer to do their review, the payer dashboard can be accessed through the medical portal by clicking on Drug Formulary Prior Authorization in the treatment section. It contains real-time information on the status of all requests. All communications regarding drug formulary prior authorization requests between the payer and the provider should go through the dashboard. This is a sample of a payer dashboard. This view contains data elements specific to the work the payer needs to do to respond to a submitted prior authorization request. It contains the name of the individual logged onto the dashboard. It provides the ability to go back to the medical portal landing page. The user also has the ability to sort and filter requests and also to assign or reassign requests based on their role or their level of responsibility within the system. For each request, the payer will see the ability to view the full request that was submitted by clicking on the URL link that's provided there. They will see the level of the request. We'll discuss the different levels in just a minute. The current status of the request, the date of the next action being due. An example here is if a request is level 1 request and the status is submitted, the action date would be the date by which the level 1 review must be completed. The dashboard provides the claimant's name, the WCB case number, the carrier case ID number, the employer, the carrier, the claim administrator name, the drug being requested, the date and time of the status mentioned, who it's assigned to, and the mechanism to do an assignment. I just want to stress here the ability to sort and filter. So if the workload administrator is assigning work based on carrier or claim administrator, they have the ability to sort and to do those assignments. So to walk through what the different fields mean, The view request provides a link, as I mentioned, that will open the prior authorization request form. It shows all information submitted up to that point. The level corresponds with the level of the request for the review. For each level 1, 2, or 3, there may be a status of REQ, request status, or REV, or review. The different statuses include submitted, which is a request has been submitted by the provider and will remain in status until an action is taken or the 4-day period has lapsed. Denied, the request has been denied. Granted, the request has been granted. Granted in part, the drug has been approved, but for a limited length of time, quantity, or number of refills from what the provider had requested. Approved by order of the chair, the reviewer has not responded in the allocated time frame. The request is deemed approved by an order of the chair. Or granted and final, the provider's time frame to respond to a level 1 or level 2 review is lapsed, or the medical director has made a final decision. Granted in part final, the provider's time frame to respond to a level 1 or level 2 review has lapsed, or the MDO has made a decision. And denied final, the provider's time frame to respond to a level 1 or level 2 review has lapsed, or the MDO has made a final decision. The provider will then see on their dashboard, as I mentioned, the due date, which is the date the next action is due, the claimant name, the WCB case number, the carrier case number, employer name, carrier name, claim administrator name, medication requested, current status, date, and time, and the assign, reassign indicator. All submitted requests will be routed to the workload administrator's dashboard. The workload administrator must assign the request to the individual reviewers. To assign a request, the workload administrator would select a line item or a submission that they want to assign, and it should be noted that multiple can be selected. They would then click the Assign Reassign button, and at that point, a pop-up will appear which will provide a drop-down list of the individuals who the carrier has indicated as valid reviewers for the particular level. The workload administrator would then select the individual that they want to assign the work to and select Save Changes. This will automatically move the particular item to the reviewer's dashboard for them to take action on. And again, they would start by clicking on the link to review the full request and see what has been submitted. After the review of the submitted request and the review of any corresponding documentation, the reviewer would then either grant, partially grant, or deny the request. If the request is granted or denied, if the request is partially granted or denied, a specific reason for the denial or partial grant should be included by entering that information into the space provided or attaching documentation. The provider's rationale for the request must be specifically addressed. If the request is being partially granted, such as a decrease in dose or quantity or number of refills, the reviewer should enter that information associated with the partial grant. The reviewer will then enter their name, title, and hit submit. The system will route the request back to the provider, as I mentioned, who will review the request. The provider will then have 10 days to submit to the next level for a review of a partial grant or denial. The workflow in the form for a level 2 request is similar, except the payer's physician will be responsible for the request once it's been assigned by the workload administrator. It should be noted that a prior authorization form moves through the various steps in the process. The form grows dynamically, allowing each subsequent step in the process the ability to see what's transpired in the preceding steps. Additionally, after each step in the process, the then current form will be filed in the injured worker's e-case folder and can be viewed by parties of interest. So that basically is an overview of what takes place during the process associated with prior authorization. So what I'd like to do now is to spend a few minutes just going over some observations that we've made over the past several months as we've been getting inquiries from pharmacies and injured workers and attorneys about the ability to obtain and receive their medications. The first thing I'd like to raise is that if an item is on the formulary and the injured worker has been established for that particular body part and associated with the medical treatment guideline, the injured worker should receive the medication, basically no questions asked. This is not an opportunity to do utilization review or to require the provider to submit updated medical. What we've seen is that formulary medications for which the patient has been established are being denied because the provider has not submitted medical recently, or a letter of medical necessity is being requested. If the claimant is established for the body part and the medication is formulary, the medication should be provided. We've been getting indications from some of the adjusters and claims examiners indicating that they have quote-unquote hard blocks in place on what are actually formulary items. So we would ask that you please check with your PBMs and make sure that hard blocks are not inconsistent with the formulary. Prior authorization requests are for non-formulary medications. As such, the medication that gets requested through a prior authorization request is obviously not on the formulary. We've also seen a number of instances where rejection for a prior authorization request just says rejected, not formulary. This is obviously not appropriate because the reason that the prior authorization request is being submitted is because the medication is non-formulary. So rejecting it by just saying we're rejecting this request because it's non-formulary isn't appropriate. A specific rationale for a rejection or a partial approval of a non-formulary medication should be provided, specifically responding to what the provider had submitted as far as the rationale for the request. We've also gotten the question, and we're seeing, and this is probably confused by the delay in refills complying with the formulary, is if a prior authorization request gets submitted for a formulary medication, what should be done with it? What we're asking is that if a request is submitted for a formulary medication and the appropriate documentation, et cetera, is there, that it be approved for up to that 1 year or whatever the provider is requesting. If a provider is submitting a prior authorization request and does not provide appropriate documentation for the medication, that a 30-day supply be approved because the medication is formulary, but that the provider be informed through the pretext portion that there wasn't a really appropriate documentation being approved. It will be approved this time, but for subsequent requests, they need to be more specific or provide additional documentation. And this actually is listed on the board's website in the formulary Q&A section that goes back about 6 months, specifically question number 23. We're also seeing that medications that patients have been on are being rejected as non-formulary. Just want to reiterate that refills, regardless of the formulary status, are not required to comply with the formulary until a to-be-determined date, second quarter of 2021. And again, a refill is a medication the injured worker has been on in the past year. A question about the handling of non-MTG body parts. Special consideration number 4 is specifically put in place for that. This addresses medications for non-MTG body parts. Formulary drugs with special consideration number 4 should be used as clinically indicated for causal or related injuries or conditions utilizing accepted standards of medical care. Special consideration number 4 is used when there is no medical treatment guideline for an established body part, or when a condition directly associated with an established body part was not addressed within the medical treatment guideline. So again, this was the example that I used earlier, the total knee replacement that then becomes infected. The antibiotic wasn't addressed within the medical treatment guideline, but it's obviously considered accepted medical care. or for the patient with PTSD that's been established, but there's no medical treatment guideline yet approved by the board. And just as a way of update, simultaneous with the implementation of Onboard, the new prior authorization system, the board will be incorporating new medical treatment guidelines specifically related to hand, wrist, and forearm, foot and ankle, asthma, interstitial lung disease, depression, PTSD, and TBI. So these medical treatment guidelines and the associated adjustments to the formulary will occur second quarter of 2021, simultaneous with the release of Onboard, the new prior authorization system, and this is also when the refills on medications will need to comply with the formulary. The formulary also should not be used to challenge dosages of formulary medications. We've seen formulary medications being rejected because it's quote unquote above the maximum daily dose, not an appropriate denial reason. If there's a concern or an issue and the carrier or the TPA wants to do a review, that's fine, but rejection of payment for the medication should not occur. We've also seen a limitation to a 20-day supply when the prescriber writes for a 30-day supply, again, not appropriate. If the medication's on the formulary and the patient has been established for that particular medical treatment guideline, what the prescriber writes should be processed. If the medication is not formulary, these issues can obviously be questioned as part of the prior authorization review. Items marked as second do not require prior authorization, but rather you should see a history that other agents in the same therapeutic category have been used. Second-line drugs can be requested for initial treatment, but this would have to be done by a prior authorization request. So if a patient had a problem with a particular class of medications and there was only one thing, in this case Celebrex, that the provider thought was useful, Celebrex is indicated as second line, but if the provider wanted to do a prior authorization to use it first line, they could. Review of a prior authorization request is the opportunity for the carrier to deny is not causal related, not when the prescription's being filled at the pharmacy. So we've also seen multiple instances where there's an approved prior authorization request, but when the patient shows up at the pharmacy to get the prescription filled, it's being rejected for causal relationship. Once a prior authorization has been approved, either level 1, level 2, or level 3, the prescription should be processed. And I just want to note that the level 3, and I had mentioned this or alluded to it earlier, the level 3 reviews, which are the Workers' Comp Board Medical Director's Office, are done based on medical necessity. And part of the revision to our processes is the statement that you see here will be incorporated into all reviews that the medical director's office is doing. So they will be indicating that their determination is purely based on medical necessity of the medication being requested and does not consider whether or not causal relationship has been established. And the review by the medical director's office should not be used to infer payment of a claim for which causal relationship has not been established. So we're hoping that that will clear up some of the confusion that's been seen also. When a provider submits a prior authorization request, the rationale the provider submits should be specifically addressed. And I know this probably sounds like a broken record, but we've seen very limited response to the provider's requests. So I just want to emphasize this. Whatever the provider's using as a rationale should be specifically addressed, both at level 1 and level 2. And again, simply responding not on formulary is not an appropriate response to a prior authorization request. And the last observation I want to raise is we've heard repeatedly from examiners, carriers, et cetera, that we've talked to, that the PBM has their own formulary. It's fine that the PBM has their own formulary, and an alternate formulary may be utilized, but the Workers' Comp Board formulary must be the baseline. If a particular carrier or TPA has a formulary that's more expansive than the workers' comp board formulary, it's fine, they can use that. But the WCB formulary should be and must be used as the baseline. So we would ask that people go back and engage their TPAs and make sure that alternate formularies aren't being utilized. And at this point, I'd like to turn it over to David for a quick discussion associated with penalties.
Okay, great. Thank you, Steve. Want to talk about some potential penalties in this area. Steve listed some inappropriate denial reasons and actions that lead to delays. So we wanted to let you know that where we see inappropriate actions on the part of the payer, such as denials of PARs on the grounds that it's non-formulary, and like Steve said, that's inappropriate given that inherently all PAR requests are for non-formulary agents or usage, or where we see actions like a failure to communicate a grant of a PAR to the PBM that leads to unreasonable delays or denials that occur at the point of fill. We'll evaluate these occurrences, and in these circumstances, this would subject the carrier and or the TPA to penalties through our adjudication process. What would happen is the matter will be referred for conciliation to see if a 114A3(1) penalty is appropriate. For the non-lawyers there, 114A3 is a statutory provision for penalties against a party who has instituted or continued an issue without reasonable grounds. And prong 1 of 114A3 is a penalty representing the board's administrative expenses. So we would be implementing 114A3(1) penalties in the amounts of $500 per instance, and if there are chronic and repeat violations by a party, $2,500 for each of those. You should know that in the event of such a decision, which would be a proposed decision coming out of conciliation, this is not going to provide an opportunity to relitigate any of the issues on medical necessity determined by the MDO or that may be determined by the MDO in the event of a level 3 review. And if there are objections, the statute calls for a reevaluation and potential hearing. But if those objections are baseless, that might result in the trebling of what that initial penalty was imposed as. The goal here is to drive behavior, not to generate funds to the board. It's to make sure that the formulary fulfills its purpose. With that, I believe I'm turning it back to you, Steve.
Thanks, David. I would like to thank people for participating. Please keep in mind that our website contains full information about the formulary. There's a very detailed set of questions and answers. There's a series of pre-recorded webinars there. And I also here want to throw in a plug for Onboard Limited Release, which is also on the board's website in its own section entitled Onboard. There's recorded webinars there, there's questions and answers, there's information about coming events. So I would ask people, since it's obviously going to have a huge impact on this group, to make sure that you stay tuned to Onboard Limited Release. So with that, I'd like to thank everybody for their participation and have a good day.